Hello, real-world clinicians. This is Ali Nessa with another real-world presentation for you. I have the pleasure of being joined today again by our own faculty, Dr. Chafic Safi, via Skype from Montreal, Canada. Dr. Safi, thank you so much for joining me today.
Thank you for having me.
Dr. Safi is an endodontist and educator. He's the founder and director of Centre Endodontic in Saint Laurent and is a graduate of University of Pennsylvania postdoctoral endodontics program, where he is currently a adjunct assistant professor and lecturer. He's also a lecturer and assistant professor at the McGill University postdoctoral endodontics program. Dr. Safi, the title of your presentation is Endodontic Management of Patients on Anti-Resorptive and Anti-Angiogenic Therapy. Now, these are basically bisphosphonates and other chemotherapeutics that are commonly prescribed today. As our baby boomer population here in the U.S. is reaching retirement age, we're all seeing lots of patients under such therapy that we really have to be very careful to manage, both from a surgical and non-surgical point of view. So I'm going to pass you the podium to enlighten us here in this topic and share your thoughts and ideas with our viewers.
Thank you very much, Dr. Nasser. So as you mentioned, this whole story of anti-resorptive and anti-angiogenic really started with bisphosphonates. And as we see in this slide, bisphosphonates are given today into various forms, whether it's an intra-oral form like Fosamax, one of the most known bisphosphonates that's given to treat osteoporosis. And on the sides of this picture, we have Zomira and Pamidronate, which are intravenously injected bisphosphonates prescribed to treat, let's say, lytic lesions in cancers and also to treat some other bone diseases such as Paget diseases. Now, despite really their great advantage and the benefit that they offer for the patient, they tend really to have a very bad side effects. But before we speak about side effects, these medications really work by halting or stopping bone resorption because they have a direct effect on the osteoclasts. And the osteoclasts are really those cells that are responsible to destroy bone, whether in a cancer disease or whether in osteoporosis. So they stop the differentiation of the osteoclast, and they also stop their recruitment into the bone sites, and they also induce the apoptosis. So overall, we have a less osteoclast and even less active osteoclast, which really makes these drugs very good in order to control anything that deals with the loss of your bone in any kind of disease. So as I said, despite their really great benefit to the patients, they tend to have very bad side effects. And in this case, what we see are the three first pictures of the first case series that was published by Dr. Marks, who was the, I think he still is the chair of the Oral and Maxillofacial Surgery Department at the University of Miami. These drugs tend to cause at long run necrosis and the infection of the maxillary and the mandibular bone. And not only that, these cases tend to be non-responsive to any kind of treatment, whether it's surgical or non-surgical treatment. As we can see, this patient on the right-hand side had her mandibula resected with a titanium mesh reconstruction, and you could really see how this has been non-responsive at all, and actually it worsened her condition. As we see, there's a lot of infection in the area and a lot of complications. So this story of bisphosphonate really started in the early 2001, and it has developed so much that in 2014, the most recent update from the American Association of Oral and Maxillofacial Surgeons came up to really reflect all the changes that has been taken into account and all the development in this field. And more specifically, now we're not talking only about bisphosphonate. We're talking about two families of drugs. We're talking about anti-resorptive drugs, which in this case, for example, we have Xgeva or denosumab, which is a drug that is given to control osteoporosis. And bisphosphonates actually land into this anti-resorptive family. And we have another family of drugs called anti-angiogenic. As their name really suggests, they control the angiogenesis or the forming of new blood vessels, which makes them very good drugs in order to control metastatic cancer lesions by really stopping and inhibiting any development of blood vessels into the cancer lesion itself. So how come these two families of drugs, despite their benefit cause these complications? Well, it turns out that these drugs cause the stop in angiogenesis, and also they cause other kinds of, they cause an inhibition of blood vessel sprouting, and they cause the inhibition of secretion of vascular endothelial growth factor into the areas where they are. And so this makes the bone where these drugs are most of the time found, which is in the maxillary and the mandibular bone. This makes this bone very avascular. On the other side, these drugs also tend to make the maxillary and the mandibular bone in a very acellular state, because they stop the recruitment, and they induce the apoptosis, and they stop the differentiation of osteoclasts. And so we have a avascular and an acellular state. So these two conditions, when we have an avascular and acellular state, this makes the maxillary and the mandibular bone very prone and at high risk of developing osteonecrosis of the jaw. So for a patient who is seeking dental treatment, whether it's an endodontic treatment, surgical or non-surgical, we as health professionals need to have a specific strategy in order to prevent this development of osteonecrosis of the jaw. And the first really point is really to prevent osteonecrotic lesion to occur. And after that, when these lesions occur, we need to be able to control the pain and control the infection. So in terms of prevention, whenever we have a patient that is actually taking these drugs and coming to seek our help, we need to avoid any kind of surgery, especially endodontic microsurgery or apicoectomies. And if we have a tooth that is non-restorable, we should not extract it. We should really have not a conventional root canal treatment, whether it's an initial treatment or a retreatment done, and we can have the crown resected until the level of the gum and seal that tooth, as to say, and this will prevent any development of any osteonecrotic lesion after that. And in terms of patients taking intraoral bisphosphonates, talking only about the surgical side of the of procedures, if the patient has been on therapy for less than 4 years, then this patient can receive endodontic microsurgery without any problem. However, if that same patient who's taking intraoral bisphosphonates or intraoral, let's say, any other kind of anti-resorptive drug, but he has another condition that, for example, diabetes, or he's taking corticosteroids, or he's taking any kind of other systemic drugs, then we should seek first of all, the approbation of his medical doctor to discontinue the drug or the bisphosphonate, for example, for at least 2 months. We do the procedure, in this case, let's say endodontic microsurgery, and then we have to monitor osseous healing very, very, very closely. We have to make sure that the surgical site has at least mucosolized before we tell the patient that he's okay to go on and take the medication again. And the same protocol applies for any patient who's been taking intraoral bisphosphonates for more than 4 years, whether he has other diseases or other systemic drugs that he's taken. We always have to make sure with his treating doctor or the oncologist that we can discontinue the drug for 2 months. Then after the procedure, we monitor the surgical site for good healing before we put the patient again back on these drugs. Now, this is talking about only surgical procedures. When we want to do non-surgical procedures, as we see, the American Association of Endodontists has published a position statement in 2010. This is one of the pamphlets that the AAE has published, stating also that surgical procedures should be avoided on these patients being treated with bisphosphonates, but that non-surgical endodontic therapy is allowed or doesn't have any contraindication. So, however, when we do a normal root canal or a normal retreatment on those patients, we need to really keep in mind these two things. That one, the patient has an avascular and an acellular bone. In other words, his bone is very weak. There are no cells in there, especially no immune cells. There's no blood in there, so it's also hypovascular. It's less oxygenated. So we need to make sure that we're not inducing any more insult or any more trauma to this bone. So when we do a root canal, before we start anything, as has been stated by Monzaid in a very good article published in the IAG in 2013, he suggests that we give all our patients a 1-minute rinse of Peridex or Chlorhexidine to reduce the bacterial load and to reduce the risk of bacterial invasion during our root canal procedure. Following that, It's very important to give anesthesia without vasoconstrictor. As I said before, the site is also hypocellular and it's also hypovascular. We don't want to cause more hypovascularity by introducing more vasoconstriction in there. So vasoconstrictor-free anesthesia is to be used on these patients seeking endodontic treatment. The third important point is to be very atraumatic and to be very careful when you place a rubber dam clamp on there. We don't want to cause tissue damage because it has been shown in many case reports that the rubber dam clamp that has been placed in a traumatic fashion can be the cause of osteonecrosis of the jaw. So in these cases, we can also try to avoid the rubber dam clamp, especially in the anterior teeth, and use those widgets or any kind of, let's say, plastic or even sometimes like a piece of a rubber dam that we cut and insert in between teeth to make sure that the rubber dam is really placed in, very well without any trauma. After that, once we accessed and we are trying to find our working length, it's very important that we try to avoid to really find patency a lot. I know it's a very touchy topic, but we need to make sure, especially in those necrotic cases where we have bacteria inside the root canal system, that we're not introducing bacteria into the periradicular tissues such as that we are really causing more trauma and more trouble to a tissue that's already hypovascular and hypocellular. And we know that finding patency, as the Billion in the 1995 article proves that it causes bacteremia. So we need to really either avoid it or tend to not really make sure of patency a lot during our treatment. The next point is we need to make sure that we are not overfilling the root canal system, whether it's little puff or big puffs. Actually, it's better now we know that maybe no puffs at all might be the best thing even in a normal patient, because these sealers, especially depending if you're using old sealers such as AH plus or all these resin sealers, tend to be very cytotoxic to a tissue that's already immunocompromised and cannot really take care of itself. So we need to really decrease the chances of inducing more trauma and more trouble to those periradicular areas. And the next point, and this is a very controversial point, Monzaid in his article suggests that all the necrotic cases, even with the periradicular radiolucency, to be done in a single visit, so as to reduce the trauma, meaning reduce the anesthesia, reduce the rubber dam placement, reduce the checking of the working length, reduce all these steps that we do during endodontic treatment. And he also suggests that we give an antibiotic prescription for these patients, preferably amoxicillin if he's not allergic, let's say before or after treatment, so that we make sure that we are really promoting the microbial control of the root canal system. And finally, once everything is done, one question is always left is that, can we expect the same success rate when we do a root canal treatment on those patients being treated with, let's say, bisphosphonate, when we compare them with other patients being treated with nothing? And long-term research shows that oral bisphosphonate does not affect the outcome of conventional root canal treatment as suggested by this study. No other studies have been done to investigate other drugs, but we can expect that there shouldn't be any influence on the success of the procedure, regardless of which kind of drug the patient is on, given that we follow the specific and strict protocol as I suggested by the previous slide. And finally, there was a case report that has been published in the GOE last year, and it says that there's a possible link between bisphosphonates and external cervical root resorption. So when we have those patients coming into our office, we need to make sure that we're investigating the cervical areas of the teeth very well clinically and radiographically to be able to detect those lesions, especially at an early stage, so we are able to treat them more efficiently and prevent their propagation, where they become really much more hard to control and even sometimes require the extraction of the tooth. And so we need really to have our eyes open in these cases.
That's terrific. Thank you so much, Dr. Safi, for this wonderful presentation. It's obviously an area of great concern to all clinicians out there, as you mentioned, and I mentioned earlier on the number of patients that we see on a daily basis that are taking these types of anti-resorptive and anti-angiogenic medications is on the rise. I wonder, so some of those clinical recommendations that you gave, I would assume are primarily for patients that are taking these meds for greater than 4 years, right?
I mean, no. Actually, the more than 4 years, the 4 years term is only if we are planning to do a surgical procedure on these patients. The vasoconstrictor-free anesthesia, the no overfilling, the no patency, is regardless of how long this patient has been on the therapy, and it's only when we are doing a non-surgical treatment on there. Because as I said, these drugs also tend to have a very high half-life. So even if you're taking it for 6 months, or even if you're taking an injection once every 6 months, these tend to stay in the bone for at least, I mean, their half-life in some cases are 30 years. So you take one injection, for the next 30 years, you still have half of your first injection, which means your bone is still hypovascularized and hypocellular. And so it's still at risk of developing osteonecrosis of the jaw.
Yeah, of course, especially with the anti-resorptives, the mechanism of action is for them to get embedded in the actual mineral structure of the bone, so that they prevent the osteoclasts from wanting to kind of get in there and resorb and remodel the bone. But I just think that it's also important to emphasize to people watching that we need to also exercise common sense in these cases. The bottom line, as a broad spectrum of understanding, is that these patients are, for the most part, have delayed healing capability and the potential for infection and breakdown of the bone. So anything that you do in that scope is a good idea. However, I just don't want this also to become one of those cases where we are, again, prescribing antibiotics indiscriminately to everyone who has ever taken any of these pills, or is, foregoing the importance of vasoconstrictor containing anesthetics in these cases that give you profound pulpal anesthesia for long enough time so the patient can have a comfortable root canal. And again, it's just kind of keeping things in mind as you have patients that have taken these for too long or may have had previous history of complications. I think your level of vigilance has to be higher. But for the most part, let's not over-treat these patients with a lot of medications either, just because they're already taking a pill. But this was really a wonderful presentation. I certainly enjoyed it quite a bit. I'm sure our viewers did as well. I was joined today by Dr. Chafic Safi, Assistant Professor and Lecturer at the University of Pennsylvania and McGill University Postdoctoral Endodontics Program, and the founder and Director of Centre Endodontic, Saint Laurent. Dr. Safi, thank you so much for joining me today.
Thank you very much, Dr. Nasser. Thank you.
And for Real Dendo, here from Boston, Massachusetts, I'm Ali Nasser, and I hope you found this information helpful.